the reason we are here is simply because we are experiencing a very almost dramatic shift in the guidelines when it comes to musculoskeletal problems, chronic back pain. Many of the standard procedures that have been used for years are now put into question because of new science, better scientific methods of evaluating the efficacy, and also the fact that outcomes are now very important when it comes to selecting the right treatments. So, for instance, surgeries of shoulder impingements, meniscal tears, and so on that are very standard are now put into question because many conservative methods and even placebos can achieve similar results. Imaging is also disencouraged because of the many false positive findings. Passive therapies, again, show no evidence of their efficacy, especially long-term, and many insurance systems around the world do not reimburse those anymore. Injections give relief, but again, short-term, and in several cases, insurance companies refuse to pay those unless it is followed by active therapies. But when we look at exercise therapy, this is an area that is becoming very strongly forward in most of the guidelines, and the evidence is very clear. It provides substantial help, long-term help, and is routinely now prescribed. But if we look at some of the articles and reviews on this issue, this is from a series of articles from Lancet, and for the first time that I have seen in the past 40 years, exercise therapy is lifted as the first-line treatment that should be considered as a routine use. This is, of course, gratifying since 30 years back, anything rehabilitation, active rehabilitation, that was in the toolbox always the last tool. Now it is the first, so this is a very big change. But when we look at the different methods used in exercise therapy, we can see that they are far from being optimal. And I just point out a few points. One is that the technology is very, let's say, low-tech, old-fashioned, and biomechanically not optimal. For instance, this external rotation of the shoulder has its highest resistance at the weakest point of the movement, and in the strongest points, it has very little resistance. So it is exactly the opposite to what it should be. The other thing is that with all these tools, the programs that therapists use, they are pretty random. Every therapist have their own preferences, and there is no structured, systematic way of treating patients. Low productivity is an issue. It's very difficult to scale something where you need one therapist for each patient and each treatment session. One area of criticism is the lack of documentation for the old-fashioned methods. So it's a little bit of a feel-good system, and it's very difficult to show the outcomes in a systematic manner. The way data-driven, device-based rehabilitation can solve these issues is by offering joint-specific optimized biomechanics. This means both the motion itself, but also the loading curve matches each joint specifically. And because of that, it is possible to build very standardized programs. With this technology, we can treat up to 6 patients at the time, and we also encourage patients to start self-care, which is actually a completely new income source for many centers. I think Dr. Knox will explain a little bit about that as well, but in many places, up to 70% of the revenue is actually from self-paying clients that never want to leave the place. And then when it comes to data collection. It's automated fully. It just collects itself as it goes. All questionnaires are automated and so on. And it is easy to put reports to insurance companies in a very effective way. And if we look at some of the issues comparing the methods, we can see that one is functional training versus isolated. And as you can see, the guy on the left, he is doing the external rotation, but at the same time, you can see that actually the shoulder is moving and is using the scapula instead of using the rotator cuff muscles. On the right, however, you can see very, very pure movement, which is fully controlled, and it's almost impossible or practically impossible to cheat in a movement like that. When it comes to spine, this is a very, let's say, descriptive picture. You can see on the left a movement which, of course, is working the back, but because there's no restriction as to what muscles are being used, typically weaker muscles work isometrically and the strong muscles work concentrically. So the hip extensors are the muscles that work here. And if you go to any fitness center, you can see people training their back. The truth is they're actually training their hip muscles, not the back muscles. The way we solve this is by isolating and fixating a patient in a certain way so that the stronger muscles that we don't want to get involved are inhibited and the spine is fully active and all the movements are fully controlled in the spinal region. Then the other thing is about how to describe these programs. You can either have it qualitative or quantitative, and most of the existing programs are qualitative. So we say that we want to exercise the external rotation of the shoulder. This is fine. You can maybe have a repetition count and maybe you can put a load, but that's about it. But when you have device-based rehabilitation using data, you can actually prescribe it very, very accurately. And by doing this, you can actually turn the values into digital form, meaning that you can both prescribe digitally and then document it digitally. And this opens a whole new possibilities in how data is used to control the whole process and population health process. We talk that movement is medicine. This is very correct, but like any medicine, too much of it can be dangerous or too little does not help. Again, when you combine structured data with devices, you can create very, very precise prescription methods. In fact, there are very many different factors that you have to consider when you prescribe loading. You have to look at the training itself, and then you have to look at the patient. And all of these factors have to be considered when the right program is built. And the way we do it is we have testing possibility for each device and each joint, where we get the real strength level of that joint mobility. And then we use templates. We use increasingly artificial intelligent algorithms, using the background data, using the information from the tests and questionnaires, and then it will provide optimal programs for each patient. And when it comes to prescribing programs, we also have to make sure that the patient is complying. And in this respect, we have a graphical interface that will show very clearly to the patient exactly the speed, the range of motion, workload, and so on, and then provide feedback as to how well they actually worked the program. And this is a very empowering thing for the patients because they see immediately if they did something good or bad. And interestingly, in our center that we use for piloting, we have about 92%. We call it compliance in Europe. I think in the US, it's more like quality measure. and compliance is something different, but we call it how well they actually took the pill, so to speak. And it's a very, very high percentage on an average, and this is what we see all over the world. We have more than 400 intelligence centers in about 45 countries. This data is from, I think, April or May, March, so it's already bigger now. We open up about 6 to 7 centers every month somewhere in the world. And also when it comes to number of patients treated, number of tests performed, or number of visits, these numbers are also growing every day. So when we talk about using exercise as a method, we very often get questions like, so what is the difference between the David devices and fitness devices? They look the same to many people. It's very difficult. You have to go to a lot of detail to really understand the difference. So we take an analog here and say that, let's say that David is like a surgeon's knife. You can be very precise. You can get exactly what you are looking for in terms of cutting. And regular fitness devices is like a kitchen knife. So you can cut bread and you can do a lot of stuff with it, but you would not use it for surgery. So this is the difference. You can use the system, our system, for very sick people and be completely confident that it is totally safe and beneficial for the patients because everything is controllable. We use this system all around the world and it's getting recognition. Like in Belgium, it is fully reimbursed. We are working with the Ministry of Health in Saudi Arabia. We have neurosurgeons in the US using the system. So it has become part of the mainstream medical systems, and we see this change happening all over the world. And as a final point, during these COVID times, it's good to remember that our method of treating patients is optimal for keeping people socially distanced, isolated from environment in a way that they can feel completely confident. In our own center here in Helsinki, we have people that are from 75 to 95-year-old, and they're all very safe in our system, and they do not feel fear about getting contracted with COVID, because the system itself is always clean. They use gloves, masks, and so on. So I urge you to think about this as a potential future marketing and let's say promotional item, because that's what it is. It is a way to treat people in the future.